Harsha, are you ready with your presentation? So you can share your screen. Welcome everyone to the 2020 Fall Capstone presentations. Thank you so much for joining. Each student will have about 15 minutes uh, for their presentations, and you should share your screen and talk through it. And then you'll have about 5 minutes from the audience questions, as well as your advisors or faculty members asking you some questions. Yeah, please go ahead.
Hi everyone, my name is Madhursha Bandaru. My project is on developing a decision tool to diagnose Sjogren's syndrome. The objective of the project is to develop a decision tool for the people with questionable symptoms to rule out or confirm Sjogren's syndrome's diagnosis. Sjogren's syndrome is the second most common autoimmune rheumatic disease. It is characterized by the lymphocytic infiltration of the lymphocytes within the exocrine glands, namely parotid glands and salivary glands, and lacrimal glands as well. The characteristic symptoms of the Sjogren's include ocular symptoms and oral symptoms. Ocular symptoms include dryness of the eyes, foreign body sensation in the eyes, and oral symptoms include dryness of the mouth, difficulty while eating or swallowing foods, and use of liquids to swallow solid foods, and swollen salivary glands as well. And many studies suggest that the duration between the onset of symptoms and diagnosis of Sjogren's syndrome is more than 4 years. And the gold standard guidelines for the diagnosis of Sjogren's syndrome is AECG guidelines. And we have developed these guidelines by the literature review of AECG guidelines and also consulting opinions from the clinicians as well. And these guidelines are validated by reviewing electronic health record data of the patients who are already diagnosed with Sjogren's syndrome to find out the findings and results of the symptoms used in the community practice settings. And a questionnaire is prepared from these guidelines. And by using framework called Material Design Lite and Cordova and Android Studio, we have developed this mobile application. And coming to the decision tree to support the Sjogren's syndrome diagnosis, the questionnaire consists of exclusion criteria and the subjective and objective findings. Exclusion criteria includes the syndromes which have the symptoms and signs which mimics the Sjogren's syndrome. And the subjective findings include the ocular signs, the oral signs, and also the medications used to relieve the symptoms of both ocular and oral signs. And the objective findings are the diagnostic tests used to confirm the diagnosis of Sjogren's syndrome, which in the community practice settings used are testing for SSA autoantibodies and SSB autoantibodies and biopsy of the labial salivary gland as well. And the functionality of the application includes 3 scenarios. The first scenario is the positive Sjogren's patient, and the second scenario is the uncertain patients. Uncertain patients have the symptoms similar to Sjogren's, but they don't have the objective evidence to confirm the diagnosis. And the third one is negative patients. They have less than 2 Sjogren's syndrome symptoms. And the limitations of the study include the usability of the application to shorten the duration of diagnosis, and also it's a standalone application and has the potential to be used by the healthcare providers as well. And the conclusion includes by developing this decision tool application to diagnose Sjogren's syndrome, the duration between the onset of symptoms and diagnosis of Sjogren's syndrome can be reduced, thus improving the health-related quality of life of the patients. And the patients with Sjogren's syndrome has 16-fold increase in developing life-threatening lymphomas. Lymphoma is a type of cancer of lymphocytes. And that's it.
Thank you, Harsha. Thank you for the presentation. Does anyone from the audience have any questions?
No. This
I
is
have,
Dr.
go ahead.
Fulton. I just have a comment and then you can talk, Dr. Jones. I thought your explanation of what Sjogren's syndrome is was spot on, very succinct. You hit the high points and you did a great job.
Thank you.
So my question was related to your decisions tree to support Sjogren's syndrome. Could that decision tree easily be adapted to other syndromes, rare diseases?
Yes. Initially, the exclusion criteria consists of the conditions which mimics the characteristics of Sjogren's. So if a patient has conditions which has symptoms similar to Sjogren's, then the patients can be excluded by this decision tree. And after answering this question of exclusion criteria, the actual questionnaire follows, which includes the information about the subjective findings and the objective evidences.
Thank you. Well done. Thank you for the presentation.
Thank you, Dr.
Thank you for the presentation, Harsha. I had a question for you. So how would you compare this sort of decision tree sort of algorithm versus, say, data focused, like a machine learning model or something that looks at the data, and what are the challenges to be able to build something like that versus this rule-based sort of?
Yes. The main challenge is to eliminate the disease, the other diseases which have symptoms similar to Sjogren's. That is the reason why we have added the exclusion criteria based on the AECG guidelines. By answering that question, we can eliminate the users suffering from other diseases.
Yeah, but my question was like, how do you follow this up with like a machine-based, like a data, EHR data, or some reported tool for further decision making? What do you see would be the challenges for that?
Challenges. I think the challenges would be understanding the conditions which have the symptoms and signs similar to Sjogren's syndrome. The user need to have certain idea. That's the reason why I have added the links as well, information links, while answering the questionnaire. Even the non-medical personnel can answer the questions.
Harsha, Dr. Purkesta is asking, what are the challenges in developing a artificial intelligence model using the EHR data? Here you have used a rule-based algorithm, right?
Yes.
Can you use a machine learning model that includes all EHR data? And what are the challenges involved?
Yes, we can use that, but the gold standard guidelines, AECG guidelines, involves multiple tests. But with these guidelines, we have used the results and the tests done in the community practice settings. That's the reason why we have developed these guidelines from the gold standard guidelines.
Okay, thank you. Any other questions for Harsha? Okay, thank you so much, Harsha, for staying on time, and congratulations for the good work. Thank you.
Thank you, Doctor.
Can we have the next speaker, Anusha, share your screen and please go through the presentation?
Yes, Prof. Good morning, good afternoon, ladies and gentlemen. I am Anusha Beatty, a graduate student from Health Informatics, presenting my capstone project. The title of the capstone is Comparison of Pregnancy and Poor Prenatal Outcomes in five Midwest states, determining if Indiana is a representative for its surrounding states, under the guidance of Dr. Kathy Fulton and Dr. Gary Shubak. Introduction. Like pregnancy and poor prenatal outcomes depends on the prenatal care. If we have inadequate care during pregnancy can lead to undesirable effects like any underlying clinical conditions such as diabetes or hypertension may lead to various outcomes. If a patient has diabetes, as he may develop gestational diabetes in the new the infant may develop gestational diabetes, and if the patient has hypertension related problems such as preeclampsia, eclampsia, the patient may suffer during the delivery. So my main aim was to identify the underlying factors for poor pregnancy and prenatal outcomes for all the Midwest states using Indiana as a representative model. The data was obtained from HRSA, Human Resources and Services Administration, by selecting variables related to the project. The variables were after selecting the variables were divided into clinical factors, demographic factors, and social economic factors. Clinical factors as in hypertension, HIV, diabetes, cervical cancer, and BMI. Demographic factors as in substance abuse, tobacco use, and socio-economic factors as in poverty, uninsured people, and people had no coverage for Medicaid and Medicare, and lack of prenatal care and prenatal patients who delivered. After dividing the variables related to our study, and the research will develop a predictive models using Spearman's correlation, univariate and multivariate regression, along with testing for differences and predictive modeling. The main objective of the study was to analyze how demographic factors and underlying health conditions were affecting the pregnancy status and its explanations, and create the predictive model using Indiana as a representative. Second is to determine if Indiana is a representative standard and a good representative model for other four states based on the design developed during our course of project. Coming to methods. In the methodology, we started extracting our data from Human Resources Services Administration from data.hrsa.gov, where we've collected all related variables. Each state had different number of federally qualified health centers. Indiana had 26, in Illinois had 45, Kentucky has 24, Michigan has 39, and Ohio were having 51. All the across all the counties, all the federally qualified health centers was taken into consideration first, and next we performed data cleaning. Data cleaning was done by looking and addressing into potential errors. For all the variable names were relatively kept short, which will be useful for further analysis. Once the data was once the data was obtained, all the missing values were replaced by 0, and irrelevant information such as special characteristics or extra spacing was removed to improve the speed of processing. And after that, our first Uh, our first analysis model was Spearman correlation. We plotted a graph for Spearman correlation, where Spearman correlation is the initial thing that we've plotted to understand whether there is an association between identified variables and poor prenatal outcomes. Following t-test. T-test compares average values of the variable of the data sets and determine if they are same across the population. We've also conducted uni and multivariate modeling. Univariate analysis studies the linear relationship between the variables. Only two variables will be studied at a time. Multivariate analysis access the steady effect of multiple variables on predicting low birth weight. Low birth weight is the only low birth weight is the only dependent variable, whereas all the others variable were independent, which we are considering in the study. And evaluation metrics used in methodology were p-value and R-square value. P-value was obtained from the t-test and R-square value was obtained from the multivariate analysis. Coming to the results. If we look into the results, the first graph that we plotted was Spearman correlation.
Anusha, sorry to interrupt you. Could you please zoom in a little? We are not able to see the results or the figures.
Yeah. Is it clear now?
Yeah, slightly better. Thank you.
Yeah. The graph, actually the graph consists of all the variables. So it is easy to, I can explain it clearly. All the variables on the left-hand side vertically and top horizontally are the variable names that we plotted. And on the right-hand side vertically is a graph measuring the values. The values, highest value is 1 and the lowest value is -1. The color and intensity of the volume indicate the strength of the variables. If it's dark, if we look into the variables, the darker blue values indicate the greater value and lighter blue values indicate slightly lesser value, and red indicates completely negative value. If it's in red, we can't see we will not able to see the values. In this graph is plotted for all the states which we are considering towards our study, like Illinois, Kentucky, Michigan, and Ohio, and Indiana. In all the states where we observed, substance abuse did not show any significant correlation towards low birth weight. Following that, we've conducted a t-test. By conducting the t-test, we've obtained mean values and p-values. Here, we start comparing all the states with Indiana. If we look into the graph, Indiana and Illinois, and we can specify that only some of the variables had significant value towards low birth weight, such as Illinois. If we compare Indiana and Illinois, poverty, Medicaid, lack of prenatal care patients who delivered, cervical cancer and depression were significant. When we compare Indiana to Kentucky, uninsured, Medicare, hypertension, tobacco, and depression were significant. Indiana, when compared to Michigan, Medicare, uninsured, hypertension, and HIV were significant. Ohio, when compared to Indiana, uninsured, Medicare, hypertension, prenatal care, and depression was significant. The t-test was, the t-test was to determine if there is any significance between the two groups that we are comparing, and further analysis was required further analysis. Univariate analysis were required to conduct the study. In univariate analysis, all the variables, large number of variables showed common significant values. So we conducted a multivariate analysis that helps as multivariate analysis considers 3 or more variables at the same time, and it is compared to all the Midwest states. If we this last table is a multivariate analysis table. If we look into the table, each state had only few variables that were showing significance towards low birth weight. In Indiana, diabetes and prenatal patients who delivered, BMI and tobacco were having significant value. In Illinois, larger number of variables showed significance towards low birth weight. Uninsured population, Medicaid, prenatal care, prenatal patients who delivered, cervical cancer, and BMI showed significance for low birth weight. Coming to Kentucky, Hispanic, poverty, and uninsured population, along with prenatal patients who delivered, showed positive correlations for low birth weight. In Michigan, only poverty had significance for low birth weight. Coming to Ohio, all the prenatal characteristics are like prenatal patients who delivered can showed significant values. Coming to conclusion, uh, all the while after conducting all the predictive and modeling and analysis, the results showed a new perspective where Indiana is not a good representative for any of the state, because when compared to Indiana, Illinois had larger number of variables that were significant, and none of and not if even though a lot of variables were significant, it doesn't match, or it was not similar with the state of Indiana. Only variable that was matching in all the states was prenatal patients who delivered. Only one variable cannot signify the strength, and it is not so. It is not a good comparison model. Indiana is not a good comparative model for any of the states. And coming to limitations, HRSA data set was the small data set, and due to the small sample size, uh, false results um, were seen. Like all the false positives were seen, and we had only one dependent variable, that was low birth weight, and all the other all the other were independent variables. So the ratio was not correct. This may lead to the differences in the results. Thank you. Any questions?
Thank you so much, Anusha, for the good presentation. Any questions for her from anyone in the audience or the faculty?
So, Anusha, this is Dr. Jones calling. Based on your research, what do you think Indiana needs to do to get better results? Do they need to collect other data, or what do they need to do?
Like I've said, my limitations was regarding the data, and if next time if we do any project related, we would consider taking more dependent variables, like not only low birth weight. As now we only taken one dependent variable and others are all independent variables. Next time we would consider taking 2 or more dependent variables, so the ratio would be equal and the results would be good.
Thank you. Thank you for the presentation. Very nice.
Thank you.
So Anusha, this is Gary. If you were going to extend this study, where exactly would you look? What sorts of things would you look at as other dependent variables that you could collect?
Like I would also see the preterm labor as one of the important dependent variable. Considering all these variables along, like all these independent variables and preterm birth, because according to the statistics which I have conducted during the literature review, preterm birth was also showing a major significance.
Okay, thank you.
Anusha, this is Dr. Fulton. You did an awesome job with your presentation, and certainly knowing the HRSA data set that we had, and that was the data that we had to use as a limiting factor because that's all we had to analyze. So you did a great job. Congratulations.
Thank you.
Yeah, if we have no other questions, thank you so much, Anusha. And we can have the next person come in. Shrikavya, are you here?
Yes, Professor.
Anusha, could you please stop sharing so she can share? Yeah, thank you.
Good afternoon, everyone. This is Shri, and my capstone project is about comparison of federally qualified health centers prenatal data from 2018 to 2019 data set and to quantify the factors affecting prenatal birth outcomes in Indiana. And Indiana has had the highest rate of poor prenatal outcomes over the entire nation, according to Indiana State Department of Health. In recent years, improving prenatal care has been one of the main concerns for the ISDH. The primary outcome of this study was to analyze the factors affecting low birth weight in the state of Indiana. And the secondary outcome was to compare variance in the variables leading to low birth weight in Indiana over the 2 consecutive years. This study used datasets that were a part of an annual reporting requirement for the federally qualified health centers at Indiana for the year 2018 and 2019. And these datasets were used to perform correlations and predictive modeling. Among these years, the 2019 predictive model had a marginally higher adjusted R-square value of 0.998 compared to the 2018 model with an adjusted R-square value of 0.997. This research's main objective is to compare federally qualified health centers' prenatal data from the 2018 to 2019 HRSA dataset and to quantify the factors affecting prenatal birth outcomes in the state of Indiana. This project's dataset was derived from the Health Resources and Services Administration HRSA. It is a US Department of Health and Human Services primary federal agency for enhancing access to healthcare services for uninsured, isolated, or medically vulnerable people. This project used HRSA datasets as a leading data source for the comparisons, which include t-tests, ANOVA, and predictive modeling for those specific years. And predictive modeling methods included linear regression univariate models and multiple regression models, and the learning platform was RStudio. The 2018 and 2019 HRSA Health Center Program Awardees data had a sample size of 25 and 27 FQHCs for respective years. The data sets individually consist of 22 independent variables, and there was one dependent variable that was low birth weight. This was considered as it was the only measure of child health that was available in these data sets. And there were 6 demographic independent variables, which include total population, children, adult population, older adults, Hispanic or Latino ethnicity, and Black African American. And there were 7 socioeconomic and lifestyle independent variables that were patients at or below 200% poverty level, uninsured patients, Medicaid patients and Medicare, homeless patients, adults screened for tobacco use and substance abuse. And there were 9 independent variables related to clinical conditions, which were hypertension, diabetes, HIV, depression screening, adult weight screening, BMI, prenatal patients delivered, and access to prenatal care in their first trimester. The steps for data cleaning assured there were no missing data or special characters, white spaces, inaccuracies, or duplicate rows. Evaluation metrics were p-value and adjusted R-square value. When coming to the results section, variable correlations were performed to study the relationships between each dependent and independent variable. And when observed in both the correlation matrices for 2018 and 2019, we could see that substance abuse had the least correlation value with all the variables and with the low birth weight. And whereas all other variables all the related to clinical conditions or prenatal patients or socioeconomic status and demographics had a higher correlation value with low birth weight of above 0.61. Even the 2019 correlation matrix, these variables remained significant, but apart from that, only the non-Hispanic remained insignificant in terms of low birth weight, and there were some variables related to socioeconomic status such as poverty, uninsured, Medicaid, and homeless, which were not found to be significant. When coming to after the correlation tests were performed, then we performed t-tests and ANOVA to check the major differences or variance or means between the differences, main major differences observed between these two data sets, and there were no significant differences observed. Next, a univariate linear regression was performed to summarize the linear relationship between the independent and the dependent variable low birth weight in both the models, and almost all the variables were seen significant except homeless and substance abuse. Then later, after this, then 4 different multivariate regression models were built to determine and quantify the relationship between multiple different independent variables with the dependent variable. And out of the 4 models, we considered stepwise as the best performing model. And as it considered only the significant variables that were independent and excluded all the independent noise variables that were least significant, resulting in the best fit model. And you could see the 2018 model R-square value was 0.997, and the 2019 R-square model was 0.998. Almost total population, children, adults, uninsured patients, Medicare, homeless, hypertension, depression, cervical cancer screening, prenatal patients, and prenatal patients delivered were found to be significant in the 2018 model. But when it comes to the 2019 model, there were many additional variables that were observed to be significant, and they were high BMI, diabetes, and tobacco were found to be significant, and they were found to be having a predictive value for low birth weight in the 2019 model. And we could also see that cervical cancer screening and homeless were no longer found to be significant in the 2019 model. And this analysis helped us to outline various significant factors leading to low birth weight in pregnant women of Indiana. And as these FQHCs advanced from 2018 to 2019, there were many additional factors affecting low birth weight. And those variables were patients with Hispanic ethnicity, usage of tobacco, diabetic patients, BMI, and prenatal care access in the first trimester. And most important points were that as per the literature, non-Hispanic patients at FQHC were no longer predicting low birth weight. Instead, Hispanic was found to be creating an impact on low birth weight model in the 2019 model, and additional variables like diabetes and high BMI were found to be significant in the 2019 predictive model. This indicates that as FQHCs progress from 2018 to 2019 to having more patients with diabetes and high BMI leading to low birth weight, but whereas earlier they're often led to macrosomic babies instead of low birth weight. And based on the literature review, to conclude, this was the only research project conducted at FQHCs of Indiana using the HRSA grantee data. And correlations and variable important analysis identified relations between variables. And these factors can aid in a new perspective for the Indiana Perinatal Quality Improvement Collaborative to improve Indiana prenatal outcomes. And informaticians can use this predictive modeling to develop predictive models and investigate the unknown relations between the variables. And this research conducted on the state of Indiana acts as a standardized foundation for further research, and it can be used to carry out further analysis on a national basis. And it provides further research opportunities for a comparative study over 2019 to 2020 due to the onset of COVID-19 pandemic, which can lead to significant differences in FQHC's functioning in 2020 due to the COVID. And further analysis need to focus on utilizing other public data sets with a greater sample size and extended variables related to prenatal care. And many other future research directions linked to the study would be of interest to scholars and across several disciplines. Thank you.
Excellent presentation. Does anyone have any questions?
This is Dr. Fulton. I do. So Shri, if somebody was going to continue on with the work that you have done, what advice would you give them in looking at the 2020 COVID HRSA FQHC data set?
Okay. Maybe they also have to try to incorporate some, they have to include some other data set along with this data set, because we just have very few dependent variables, maybe something variables related to like infant mortality rate or many live birth percentage. We have to search some statistics related to these kind of variables and include in our analysis to have more accurate predictions. And with this data, I think we can perform, these were some of the predictive models I performed. I think we can perform more analysis to have even more accurate prediction.
Excellent, thank you. Plan on keeping in touch.
So Shri, this is Dr. Schwebach. If you were going to go to IFCA, the Indiana Primary Healthcare Association, with these results,
Yes.
what would you tell them about the change from 2018 to 2019? If you had to summarize from a practical standpoint, what happened between these 2 years?
From 2018 to 2019, I think there were just 2 additional FQHCs that were added, but I didn't find more major significant changes in the data, but I could find that there were more patients being screened regarding diabetes and high BMI in the 2019 when compared to the 2018. And we also found that there were many patients reported regarding the tobacco usage and in the 2019 data set than when compared to the 2018. And yeah, that's it.
Okay, thank you. Good job, good job.
Great presentation. I just had have a question. How many patients were there in this data set? Yeah. What was the total sample size?
The sample size was based on the federally qualified health centers in Indiana. First had just 25 federally qualified, 25 FQHCs were present in the 2018 year, but in the 2019, 27 FQHCs were present.
Okay, so do you get patient numbers or?
Yeah.
Do you know how many patients were there?
It will be around like 50,000.
Okay.
Or more than that.
So,
But the data.
ask a question?
I'm sorry.
Go ahead.
Go ahead, Josette. I just wanted to follow up saying this is aggregate data and this is not patient level data, right, Kavya?
Yeah, yes, Professor.
Okay, that's what I was asking. Thank you. Yeah.
So, Sri,
yes, Professor.
We could have better healthcare outcome in Indiana if we had a better data collection. Is that correct from listening to your presentation?
Yes, Professor. Other than the HRSA data, if we could take a greater data, larger data set which had more predicting variables other than this. In this data set, I just had low birth weight. So if we had some main variables like infant mortality rate or maternal or variables related to maternal outcomes and live birth percentage of babies, and maybe we could have better and accurate models and better outcomes.
And so this, like IFCA is not able to make changes in their care because they don't have enough data to make their decisions.
Yes.
Correct?
Yes, Professor.
Thank you. Very nice presentation.
So I had this question. So when you mentioned that you use adult population and total population and these demographic independent variables, are these coming from like census tract or the catchment area of the FQHC, or is it part of the?
It is actually the number of patients who are going to FQHCs for the care, Professor.
Oh, okay. So it's like the patients who visited and not necessarily the population. Okay, thank you.
Yes.
Okay, if there are no other questions, thank you. Deepak, you are next. Do you want to share your screen and move forward? Deepak, are you there? Oh, sorry. I think I got notice that Deepak won't be presenting. Christine, are you ready with your presentation, or we could take a break for 5 minutes if you're not?
I'm ready.
Okay, yeah, so please go ahead then.
Okay. All right. Can you see the screen?
Yes, we can.
Okay, great. Thank you so much. Good afternoon, everybody. My presentation is looking at standardization of cerebral spinal fluid shunt operations in pediatric neurosurgery. We analyzed the analysis of clinical outcomes and provider perceptions from a standardization protocol. So insertion of a cerebral spinal fluid shunt is a common treatment for hydrocephalus, which is a condition where there's excess spinal fluid on the brain. The shunt catheter is placed into the cerebral ventricle, which is connected to a valve. As the CSF builds up in the brain, the valve opens and allows the fluid to drain through the remainder of the catheter, which is typically placed in the peritoneal cavity of the body so the CSF can be absorbed. Creation of this technology revolutionized hydrocephalus treatment, but over the years, numerous shunt types have been created by many different manufacturers. There's fixed differential, volume regulated, gravity actuated, and programmable options. Studies have been done to identify the superior shunt valve type, but none have been successful. So due to a lack of clear options, shunt type is typically just decided by surgeon choice. This study is important because medical cost management and quality improvement have become increasingly important in the healthcare industry. So the study aimed to show how standardization of shunts can affect clinical outcomes such as cost, length of stay, operative time, and then additionally, the study aims to measure the provider perception on the standardization, and standardization is a key piece of quality improvement. As mentioned previously, no studies have yet been done to determine which shunt type is superior. So this, the aim to understand the effect of standardization would have on clinical outcomes. And then if this is significant, it has the potential to change the way shunt surgery is practiced. There were two main research questions to this study. First, we wanted to know if the standardization of the shunts would affect clinical outcomes, and those clinical outcomes are cost, length of stay, and operative time. And then we also wanted to understand what the provider's perceptions of the standardization protocol were. So for the methods, we use the pediatric neurosurgery department at Riley Hospital for Children. We use this because we knew their standardization protocol. They standardized the shunts to allow surgeons to pick from two options. One was programmable, one was fixed pressure. And then we surveyed members only of that team because we knew, all of the details of their standardization protocol. I used the PubMed database for the literature review. Keywords included standardization, surgical, neurosurgery, cost, and outcomes. We filtered to look at the last 5 years, human subjects, and the English language. And then articles were excluded if there was no use of standardization or if there was no measurement of costs or outcomes. The results from the review showed that, again, no studies have been completed. There were numerous studies that looked at standardization, including appendectomy and colorectal surgery. These studies did show improved cost and improved patient outcomes. There were some studies showing standardization within neurosurgery. Those focus mostly on surgical site infections, but they did show positive results. So this showed us that standardization within neurosurgery is feasible. For the clinical data, we hypothesized that the results would show standardization protocol decreases operative costs, length of stay, and operative time. Alternate hypotheses were that the standardization would increase the length of stay and operative time, but decrease cost. Or standardization will increase costs, but length of stay and operative time will decrease. And the null hypothesis was that standardization would increase cost, length of stay, and operative time. For the survey data, we hypothesized that it would show positive attitudes toward standardization. We did use PLS-SEM modeling to show user factors in patient care, and we hypothesized that it would determine responder opinion towards standardization will be positive. Alternate hypotheses for the survey data that respondents would demonstrate negative attitudes towards standardization, or that only patient care would show a causal relationship to determine provider opinion. And then the null hypothesis that responders will show negative attitude towards standardization. User factors and patient care will not show a causal relationship. So the clinical data was gathered over 2 time frames. The first was that pre-standardization period from January 1, 2016 to 12/31/2016. There were 132 data points for that year. The post-standardization is the calendar year 2018, and that had 158 data points. That 2017 year was used as a transition period to implement the standardization protocol. And then for the survey data, it was sent to 20 participants and we got 13 responders. The Mann-Whitney-Wilcoxon test was used to determine if our data was normally distributed. The data, unfortunately, was not, so the analysis was done using summary descriptive statistics. And for the survey data, the partial least squares structured equation modeling was identified as the best analysis method. And this supports defining causal relationships and typically works well with small sample sizes. Using the Smart PLS software, we did do numerous attempts for modeling, and unfortunately they were unsuccessful. We attribute the failure to the small sample size as well as a small number of indicators. So we just used summary statistics as well for the survey data. So above are the summary statistics for the clinical data. This is shown as averages. As you can see, the length of stay decreased by 0.81 days. The cost decreased by $473.82. Operative time did show an increase between the 2 periods of 89 minutes. So from the survey data, these are represented in percentage format. As you can see, 5 out of 6 of them provided a clear indication of a positive attitude towards standardization. The last question asking as to whether it was easy or not is kind of a wash. There were no clear opinions on that particular question. And then here are a couple of the modeling attempts that we used from the Smart PLS software. The consistent PLS bootstrapping is pretty much the gold standard for analyzing these models. Unfortunately, those attempts failed to calculate. So this is these models here show just the simple algorithm. And you can see that most of the numbers look okay, but we struggled with the patient care indicators, and the R-squared numbers aren't as we would like them to be. So in conclusion, the study shows that standardization of shunt surgery and pediatric neurosurgery improved cost and length of stay, but operative time was increased in the post-standardization period. The survey data does show that providers have a positive attitude towards standardization. For future work, there should be additional studies to analyze these more in depth. Analyzing this beyond descriptive statistics would be valuable in gaining a better understanding of how the standardization affects the clinical outcomes as well as provider opinion. And then conceptualizing the model through the Smart PLS software can provide a little bit more information as to which indicators lead to provider opinions. Also, more data points would be helpful and provide a little bit more information. Here's references, and does anybody have any questions?
Thank you, Christine. Any questions?
So, Kristen, this is Dr. Schwabach. When you talk about getting more sample size, how realistic is it to be able to replicate this in multiple institutions across the country, as you need that same 1-year period between standardization and non-standardization?
Yeah, I think it's realistic. I think it needs to be expanded. Expecting to see this type of thing in pediatric neurosurgery might be a stretch, but I think if you expand it to additional service lines, maybe general surgery, ENT, things like that, I think it would be much easier. I think it's just going to take a little bit of time to get that information.
And that trade-off between time and surgery versus the lower length of stay and lower cost, is there some way to attach an economic number to that? I mean, on balance, how big of an improvement, if you look at it holistically, do you think that would be?
That's a good question. I'm not sure. I'd probably have to go back and look at the data to think about that. I don't know the answer to that.
Okay, thank you. Very good job. Very good job.
Thank you. Thank you.
Christine, one of the questions I had was, how do you find like the survey? Would it just be different by having more? Like, would the R-squared values be better by simply having more data, or is it that the model cannot be represented for the factors that you're choosing as your formative factors in your model?
I think maybe a little bit of both. I think it would have been easier if we had more data, but I also think having more indicators would have helped in figuring out which indicators should be included and how they should be connected.
And also, could you talk a little bit of the model that was there and like the R-squared and the relationship between the factors?
Yeah, let me go back just a little bit. So on this first one on the left, we want these numbers to be as close to 1. And we can see here, this is the negative 0.5. This one's negative 0.8. So over here, we kind of changed where our connections were. We took out this one that's the negative 0.5 and added this one here, which showed a pretty good number here, this 0.78. And this one actually improved slightly. But again, this was done with that basic PLS algorithm, so I'm not sure really how valuable this is to look at, if I'm being honest.
And so it seems you're saying that user factors really don't make, which is like gender and role, don't make a big difference in their opinion for the standardization.
Correct.
And you're saying, however, that patient care outcomes like safety and care makes an impact on like improving efficiency and reducing cost, right? So,
Yeah.
so improving care and reducing cost sort of has some relationship based on the opinion from the physicians, right? From the surgeons.
Yes, that is correct.
Okay. Any other questions from anyone?
So I asked already my questions on Monday night to Christine. Correct?
Yeah.
So we talked about user have no impact, and that it is the importance from human factors engineering. It's very important to understand the user within the problem. Can you elaborate a little bit on that, Christine? The importance of the user in the problem that you are researching.
Yeah, so I mean, previously before the standardization protocol, it was totally up to the surgeons to determine which shunt they needed. And that brought us to, having 30 different shunt types. So by standardizing that, you can kind of take that user factor out. And then from there, you can figure out how does that affect the patient care and how do providers feel about that. Does that answer your question? I feel like you worded it differently on Monday and I was able to answer better.
Thank you.
Thanks.
Any other questions from anyone? If not, thank you, Christine. Great presentation. Thank you so much.
Thank you.
We have Melissa next. Could you please share your screen and present?
Hi, guys. Let me. Can you guys see it okay?
Yes.
Okay, hold on one second. Okie doke. So, Hi, everyone. My name is Melissa. My project is identifying risk factors for emergency department diagnosed cancer through the Health Information Exchange. Here is a table of contents, just to give you a summary of my project and my thesis. So the objective of my project was to identify risk factors associated with emergency department ED diagnoses of cancer through the Health Information Exchange. A little bit of an introduction to my project. 17 to 29% of cancer diagnoses occur in the ED. Previous research has shown that patients diagnosed with cancer in the ED are found to have advanced cancers. Additionally, previous research indicates that early detection of cancer improves survival rates, reduces morbidity, and improves symptom relief. There is a lack of research concerning identification of ED diagnosed cancer risk factors through the HIE. I am currently part of an ongoing research team at Eskenazi Health, which we've been completing surveys on lung cancer patients within Eskenazi Health system. The database of patients we researched was created by the Reagan Streif Institute. They use the Indiana Health Information Exchange to create this database. And we access these patients through the electronic medical record system, EPIC. Our surveys consist of the following: demographics, cancer history, post-diagnosis, outcomes, and COVID-19 related issues. For my thesis, I chose to only focus on lung cancer patients and create a statistical table which showcases demographic information from these surveys. So a little bit about the background of my project. ED diagnosis of cancer has been deemed a failure in the healthcare system. In one study, they posited that previous research has shown that ED diagnosis of cancer signifies widespread problems with referrals for assessments and lack of access to care. And utilizing the Health Information Exchange may be the key. According to another study, the HIE allows healthcare providers to share clinical and administrative data. Furthermore, the HIE is beneficial in that it is cost-effective and improves patient care. The HIE provides access of pertinent patient information across health systems and various providers, and provides a mean of communication between providers and other providers and patients and providers. The HIE will be crucial in gathering information to help reduce ED diagnoses of cancer and increase early diagnosis. So according to another study, lung cancer is the #1 cause of cancer death worldwide, with 28,600 patients diagnosed with lung cancer each year. Research has shown that that 59% of patients ED diagnosed were stage 4 metastatic disease cases, and mortality for these patients were 54% more than non-ED diagnosed patients. So little bits from my literature review that I found really important. In one study by Murchie, they stated that people diagnosed with cancer following emergency presentation have poorer short-term survival. To what extent this signifies a missed opportunity for earlier diagnosis and primary care remains unclear, as little detailed data exists on the patient general practitioner interaction beforehand. And according to another study by Melvin, the HIE is significant to healthcare providers by reducing the following: healthcare costs, ED stays, admissions, radiographic imaging, and consultations. However, the background research indicates that the HIE is not adopted due to workflow disruption, time constraints, and usability issues. So in order to properly utilize the HIE to identify these risk factors for ED diagnosed cancer, we must I looked at the CAR study. The authors of this study were able to conduct a predictive model that was able to discover ED patients who frequent EDs within a region by demographic and clinical characteristics. This study would be a useful archetype that I used in my research, and hopefully I will use in the future when creating a model to identify patients who are likely to be ED diagnosed with cancer. So a little bit about the analysis and requirements of my project. So to solve this issue, I created a table of prevalent demographic data, and I also pulled some statistics from REDCap, which I used, pertaining to patients who were ED diagnosed with lung cancer. And to prevent the prevalence of ED diagnosis of cancer patients, I aim to eventually create a predictive model by utilizing the HIE. And creating this predictive model, I believe providers can identify these high-risk patients and screen them earlier. So a little bit about the design of my project. First, the Regenstrief Institute created a database of patients for us to examine by pulling them from the Indiana HIE. For those of you unfamiliar with the Institute, it is an organization that strives to create healthcare innovations and conduct studies. And one area of their study is global health information technology standards and interoperability. The Indiana HIE was created in 2004, and it pulls 50,000 healthcare providers in Indiana and neighboring states. From the HIE, patients across various hospital systems who are ED diagnosed with cancer can be identified. And further, as researchers, we use this HIE to investigate these charts, gather information to complete our REDCap surveys. We use the electronic medical record system, EPIC, to find the data, and we were privy to data such as laboratory, pathology, radiology, ED department information, and hospital encounter information. It also allowed us to gather information from outside hospitals and various departments. For this research, REDCap and a record status dashboard were used to log data concerning the research subjects. The subjects were selected from a Regenstrief Institute HIE constructed database. Each patient had a correlating record ID, which would include the following sections: demographics, cancer history, post-diagnoses, outcomes, and COVID-19 related issues. Only lung cancer patient demographics were analyzed. Out of the first 100 ED diagnosed lung cancer patients surveyed, 93 met eligibility requirements. They had concerning imaging or lung cancer diagnosis. And I used Excel, which showcases, I created table 1, which showcases demographic characteristic prevalence. And for future research, I plan on using SPSS to create a predictive model using univariate and multivariable regression analysis. Here are just some examples from the REDCap questionnaire. This is just a page from our demographics section. So you can see the record ID. We asked if they met criteria, their age, gender, ethnicity, race. Here is another example from the data exports from REDCap. So there was a lot of information to be found there. This just shows you the percentage of those that met eligibility, 91.7% out of the 100 that I looked at. And here's a table 1 that I created, which I will discuss the results in this slide. So from the REDCap statistical output, notable demographic findings included gender, race, family history of lung cancer, comorbidity, age, social history, and primary care provider involvement. Of all the patients studied, 54.9% were female and 72.5% of the patients were African American, whereas 27.5% of the patients were white. Out of the total patients, 90.9% stated that they did not have a family history of lung cancer, and 62.5% of patients had chronic pulmonary disease. Patients most likely to have lung cancer from the subset were found to be between the ages of 60 and 69, and overwhelmingly, almost 100% of the patients were tobacco users. Prior to the diagnosis, we found that 92.1% of the patients had seen a PCP, and that 88.2% of the patients had a PCP listed in the system. So some discussion points. Certain demographic characteristics are prevalent among ED diagnosed lung cancer patients. The HIE is a beneficial tool in gaining insight into cancer-related patients and can be used to create a database of patients, access pertinent patient data, provide communication between providers, and communication between patients. By furthering this research, the effectiveness of utilizing the HIE to create a predictive model will be gleaned, and by creating this predictive model, solutions to reducing ED diagnosis of cancer can be addressed. To sum up, the HIE is a beneficial tool that can assist providers and researchers in learning about patients. In response to identifying risk factors, the HIE is a useful tool in creating patient databases to gather information. ED diagnoses of cancer, it's prevalent and leads to poor patient outcomes. Continuing this research and creating an effective risk identification tool is the first step in addressing this issue. Other research should focus on cultivating screening tools and methods that may help providers diagnose these patients sooner. And that's it.
Excellent. Thank you. Any questions from anyone?
So, Melissa.
Hi.
Hi, thank you for your presentation and for the update of the presentation. How do you think, or what do need to happen in order that we can diagnose those cancer earlier? Or is it just a fact that they will come to ED and only be diagnosed there?
Well, hopefully. So it's the research that I'm doing right now, it's ongoing. So unfortunately, my sample size was small. And we're going to look at different cancers as well. So this is just lung cancer, and we'll have probably thousands of patients. And then we're going to look at colorectal and breast, and we're just going to see, we're going to pull all those factors that they have in common and see if we can create a system that will like ding these patients with an epic and say, hey, this patient might be at high risk. You might want to screen them earlier. Most of the patients I analyzed, they had never had a CT scan of their chest, which is what providers use in the ER or in primary care to screen the patients. So almost none of these patients had ever had one prior to the ED visit.
So
sorry.
If I understand you, you want them to give kind of a reminder to the PCP from, hey, this patient is at risk, don't wait until he gets too sick and ends up in urgent care or emergency.
It's not, so sorry to interrupt you. Maybe not even the PCP, because some of them don't even have a PCP, but just like have a provider that might be in charge of this and maybe call them and say, hey, you need to come in. We'll set you up with an appointment for this. At least at Eskenazi, the patient population is very vulnerable, and they don't have access to care that most patients do in other locations. So they're all really high risk, and just getting to them sooner, I think, is the answer.
Could it be useful to involve other healthcare workers like social workers in this case?
Oh, definitely. Definitely. I think a full collaborative effort between all providers, all types of providers. Could be
Thank you. Thank you.
Yeah, sorry, I talked really fast.
Melissa, how would you sort of compare the data that you got from INPC with the data that's in the Indiana State Cancer Registry? Because I know the lung cancer data is in that registry.
You know, I'm not too sure because I haven't had a chance to really look at that. I'm so sorry.
Okay, no problem.
Sorry.
And could you also talk a little about, maybe I missed this on the slides, the years for which you have this data, and I know we weren't able to see the exact number because it was like unclear from your slide what the total sample size was that you found.
So I just pulled a subset of the current research that we're doing right now. So every day we've been screening these patients or screening the charts, and one chart to go through the information that we're like, it takes a whole day to go through one chart, and there's 4 of us that are doing it. So it's ongoing, and it's as many patients as we can find within the Eskenazi system that meet our criteria. So we don't have a total yet of that. So I just pulled the first 100 to look at. My next step, because I want to continue this research even after this thesis, I want to compare these patients for emergent patients versus non-emergent patients that clinically present. So I know that wasn't your question, but 100, and then 93 of those 100 met the criteria. And they're from many years apart. Some are current, some have passed away, some are from like 20 years ago. It just depends.
Okay, because that's what was interesting, is because if you have too old data, then probably the way for diagnosis or the age at which the diagnosis happened is probably different from what you can do today.
Yeah, it is very not like standardized. Like some of them are staged. Some of the like providers just say that they have like cancer, but they don't go into it. It just kind of, it's a mixed bag of information, which it's been very difficult sifting through it and finding the accurate data. Oh, I lost my train of thought. Oh shoot, sorry.
Never mind. Thank you so much. Are there other questions?
Please note that students can ask questions too from your peers.
Okay, thank you. Let's have Manoli present next. Manoli, can you share your screen and present, please?
Yeah, sure. Can you see my screen?
Yes, we can.
Okay. Hi, everyone. My name is Manoli Patel, and I have done my project on gigification of healthcare under the guidance of Dr. Jones and Dr. Fulton. So what is gigification? Gigification is defined as a form of hyper-flexible work where workers can offer their time to organizations and consumers in the market through a digital platform, often known as an online business platform. Gig work is usually refers to a job or a task, which is a short-term employment with a business on a specific assigned task for a limited time period. There has been a growth in gig work significantly in the past few years. Likewise, gigification in healthcare has also been increasing with the temporary hiring of nurses and other healthcare providers. The objective of this literature review study was to elaborate on gigification, its current status, and its potential in healthcare. The question proposed for this review was, how can gigification be applied to the healthcare industry, and what would be the challenge of doing so? So a little background on gigification. Gig work is known for crowd work and on-demand work. Crowd work involves the remote buying and selling of digital labor, and it's often known for its feature of remote work, making it highly mobile and convenient. The main difference between crowd work and on-demand work is that crowd work is done online through a digital platform since it's remote, while on-demand work is linked to on-site jobs where workers go on-site and work for a specific task for a limited time period. The term gig economy was coined in 2009 by a New York editor, Tina Brown, who introduced the term and predicted its tremendous growth in the gig economy, and she also thought that it would redefine professional jobs. She was true in the fact that it did increase. The gig economy workers did increase, but mainly for unskilled workers, such as drivers, delivery people, personal assistants, cooks, babysitters, but not so much in the knowledge work industry. However, technology has given a rise to knowledge workers, and it has also seen growth in that perspective. So the methodology portion of my paper was literature review was conducted through searching Google Scholar, Scopus, and APSCO CINAHL complete databases, where no time period was needed for limitations since gigification was a fairly new topic. And non-peer-reviewed publications such as blogs, news articles, and journals were also selected for the study because we needed to get an insight on individual opinions, as well as latest news updates regarding the topic of gigification in healthcare. A total of 23 articles were used for this study, including both peer-reviewed and non-peer-reviewed publications. The articles were validated by independent reviewers. As you can see, I'm sorry, the Excel spreadsheet, I took a screenshot of it. It's really small, but that's how the methodology section was done. We interpreted all the articles and we selected a total of 23. And that Excel spreadsheet explains why those 23 articles were selected compared to the other articles. So for this results section, we found that nearly 50% of millennial workers are part of the gig economy currently, and based on the current growth rate, it has been estimated that gig workers are to become the major workforce by 2027. And likewise, there is also a need of gig work, especially in healthcare. It has been estimated that there will be a shortage of 122,000 total healthcare workers by 2032. And due to the current COVID-19 pandemic, there may be also structural shifts coming in the economy due to this pandemic, where the recent norm of remote work will become more common. So there might be an increase in knowledge workers as well. And according to the US Census, the population of Americans living in the rural areas went down from 54.4% in 1910 to 19.3% in 2010, which has caused adverse effects in the rural parts of the nation because of the lack of healthcare personnel in those areas. However, a company that provides gig platform is Nomad Health, which is known to be the first online freelance healthcare jobs platform. And it provides a solution to the shortage of the nation's nursing staff because it is known as the first short-term nurse staffing company. And along with the advantages of gigification, there are also several challenges. So the main challenge related to the gig economy is that the challenge of health benefits provided to the gig workers. So gig workers usually do not have any health insurance because they're still considered as part-time workers. And another challenge involves the need for consistency of training to ensure that gig staff provide high quality of care, especially in the healthcare area. Clients such as Nomad Health, who help gig workers find gigs, usually do not offer them training to upskill them. And the organizations, the healthcare organizations which are hiring gig workers, should not be responsible for training these gig workers. So it is usually the responsibility of the gig workers themselves to train for their job responsibilities. And it has also been noted that gig workers who work in these professional organizations with big organizational firms and organizational cultures, they're also not able to fit in easily with other employees, as they're often seen as outsiders. And however, with the gig economy, there are pros and cons, pros related to the flexibility in time and workplace for gig workers, as well as cons related to adapting to different organizational culture. However, with the challenges, there are also some resolutions to overcome these challenges. For the challenge associated with the lack of healthcare coverage for gig workers, there's a company called HealthTap, which actually provides gig workers or part-time workers or contractors healthcare coverage. So for discussion, it can be inferred that the gig economy offers several advantages for its workers and employees. The gig economy helps entrepreneurs minimize their labor costs and gain maximum output by hiring gig workers, while gig workers gain the advantage of having work hours and work locations and being able to choose their schedules accordingly. The healthcare system has slowly started to shift to the gig economy, which can be observed in the temporary hiring of nurses, doctors, technicians, and other clinical specialists. Nomad Health serves as a prime example of how a health system could easily hire temporary workers at will and be able to get the benefit of having gig workers. The use of gigification helps eliminate specific challenges faced by the current healthcare industry. For example, the issues related to not having enough healthcare personnel, especially in times of COVID-19 pandemic, or the shortage of healthcare personnel in the rural parts of the nation. The quality of care provided to patients may improve over time due to the gig economy, but there's not enough research to prove this yet. In conclusion, although the literature review gives a better understanding of the gig economy in healthcare, it also shows there's still a lack of research to determine its impact in healthcare itself. Therefore, further studies need to be conducted to fill in the gaps for various overlooked areas in gigification of healthcare. And the limitations of this study did include that there were only a few articles available for information specific to healthcare, or for especially in knowledge workers. A lot of studies were found for gig work and unskilled workers, but not so much for the knowledge work industry. Thank you.
Thanks, Manoli, for the presentation. Does anyone have any questions? I think Jiaping, do you want to mention this, or maybe I can ask that question? So Jiaping has asked, you discussed the pros and cons of gig workers and employers, but is there any research on how health gigification impacts patients?
So not exactly, not directly. Gigification, there are studies that having gig workers be available, so it cannot be directly proven by this study. That's why I could not prove the cause of gigification in healthcare entirely, but it has been studied that gig workers who are able to take in places where especially there's short healthcare providers like a shortage of healthcare providers, they're able to provide service and that may improve patient care, but there's no real studies out there which prove this yet. I hope this answers your question.
Thanks. Any other questions from anyone?
Hey, Manoli, this is Dr. Fulton. If somebody wanted to pursue this topic, let's say next semester, for a capstone, what advice would you give them?
I feel like when I initially started this project, I was comparing health information technology with gigification. I think looking into it with health information technology with corresponding with gigification would, and as well as focusing more on knowledge workers instead of unskilled workers, that may give a better understanding of the topic itself.
Awesome, thank you.
So Manoli, thank you for the presentation, well done.
Thank you.
So you discussed how gigification at this time, the only research is that we have is that they can provide the necessary healthcare workers when needed, like in the COVID epidemic, but we have no data about how they impact the care or at what level, the professional level, the non-professional level. So we have no data about this. Do you think that we need to look into it as an opportunity or not?
I feel like it would be an opportunity if there was data available, but knowing and searching through Google and through other databases, I found that there's not much data with gig work itself to be able to conduct a data analyzed study. But that would be a future perspective for sure if there was data to look into it.
Thank you.
Thank you, Dr. Jones.
Thank you, Manoli. Any other questions for Manoli? If not, we can have the last presenter. Yvonne, are you there?
Yes, I'm here.
Okay, please go ahead. Share your screen and begin presentation.
Can you guys see my screen okay?
Yes, we can.
Okay. Good afternoon, everyone. I am Yvonne Parker, and my project is on assessing the need for standardized telehealth billing regulations. The Center for Connected Health Policy defines telehealth as a collection of methods for enhancing healthcare, health education delivery, public health, and support using telecommunication technologies to administer virtual medical, health, and education services. Telehealth has been around for at least 50 years, but barriers such as reimbursement, technological, and legal standards has hindered its adoption. Telehealth reimbursement is also burdened by narrow or broad coverage policies and geographic restrictions. My project aim was to determine if there's a need for the standardized telehealth billing policies for private healthcare insurance. A literature search was done. There were thousands that resulting in on the topic of telehealth, but there was none specifically related to each state's billing regulation. So currently there are no standardized telehealth billing regulations for private healthcare insurance across the Midwest region of the United States. I chose the Midwest because of the population and its weather. As we know, the summers can be really hot and the winters can be brutally cold, which results in many retirees choosing to vacation in Florida during the winter months. The standardization is crucial because patients relocate and visit other states for extended periods of time, but these patients will still need to have their doctor visits and get prescriptions filled. Each state's telehealth billing laws was compared to observe which state's policy could be implemented comprehensively. The state's law differed by way of how broad and narrow the descriptions were. I found that states may or may not have a telehealth parity law, which means the private insurance must cover telehealth services comparable to coverage and reimbursement as it would be for in-person care, so face-to-face. A state may have a service parity, a payment parity, or both. The graph, this top graph of the United States shows that only 3 Midwest states have a payment parity. The orange colored states have a parity and the blue states do not. You can also see that there are comparison tables of healthcare professional, telehealth licensure requirements, and e-prescribing requirements. Each state has its own definition of the scope of telehealth, which is the extent of telehealth standards. For example, Ohio's scope includes oral, written, and electronic communication, while Florida's scope only mentions asynchronous and synchronous usage. Each state also describes what services are covered by private insurance. Say Indiana's law only mentions synchronous and asynchronous coverage, but Florida covers asynchronous, synchronous, and remote patient monitoring. The state's licensure laws were pretty much all in agreement that the provider must be licensed in the originating site, which is where the patient is located. Some states gave an exemption if they were called in under the license of a professional who's in that state already for a consult. As you can see that most of the Midwest states require a prescriber-patient relationship to be established. But Florida's was more restrictive and they only allow for specific circumstances, such as a provider can only e-prescribe to long-term care facility patients. In summary, there should be more research done on the telehealth policies in each state to know if the states are succeeding or failing to provide fair reimbursement and coverage to providers and patients. My proposed solution would be to, instead of various definitions of telehealth billing policies in each state, there should be a standardized policy across the United States. When providing a standardized policy, there will also need to be a uniform definition of telehealth scope with regulated licensure requirements, covered services by insurance, and e-prescribing, since these are closely related to the telehealth reimbursement policies. The foundation can be built from the parities, which should be a reimbursement and service parity. This standardization can be achieved. Currently, since the COVID-19 pandemic, the CARES Act has been implemented, which includes a telehealth section to provide temporary changes, waivers, and easing of restrictions regarding billing for private and public insurance. Achieving a permanent solution will be adopting standardized telehealth billing regulations that will help overcome current issues with reimbursement, covered services, licensure requirements, and e-prescribing. Thank you.
Thank you, Yvonne. Any questions from anyone?
Thank you. I have a few questions for Yvonne, or one major question.
Okay.
So Yvonne, every state has kind of their own guidance and scope of telehealth.
Yes.
With that, with the COVID, the pandemic going on, what is the major drawback of that?
Of the pandemic?
Or no, of having these different regulations for different states, and that the COVID is going on and that people have the mobility from state to state?
The major drawback for that is they still have to abide by the state's policy, where we see some were very narrow and some only mentioned one sentence of, oh, long as you use telecommunications, you are fine. But as I mentioned, the CARES Act gave a blanket policy that applied to private and public insurance, and they gave the states the advantage to lessen up restrictions and licensures. So a prescriber in Ohio didn't have to get his license in Texas to see a Texas patient. Everybody is able to see, long as they follow certain criteria. Just say if it's they're going to the doctor for a COVID complications, or specifically they mentioned lung complications, since that is a big complication with having COVID. So after this temporary restriction is lifted, they'll have to go back to their own state's guidance, which some, as I said, is very broad, and patients will have to contact their insurance or the facility to get clarification before they are even seen to know the reimbursement policies, because there are some states who reimburse at a different rate. If I go face to face, you'll get the the physician will get 100% of the rate, versus, oh, if I see you online, I'm only getting paid 70% of the rate.
Thank you. Thank you for the presentation.
Thank you.
Any other questions, anyone?
So this is Dr. Schwebach. Yvonne, if you were going to try to put a national system together, how would you go about doing that based on the data you're seeing? What have you thought of any features that might be best for a national system versus just, or a standardized system versus the statewide things? What would you propose doing?
I would propose, since most states have a parity, whether it's payment or coverage, I would say that we need to have both payment and coverage to say exactly what you can be seen for and how much the provider is going to be reimbursed. And the scope goes a long way. Many states do say, hey, we'll allow remote patient monitoring, but some states don't. I was really intrigued by Ohio. They say that telehealth is any kind of written communication. So that would include fax and email, which seems kind of bizarre to me. I didn't have anybody, of course, to confirm that with, but that was in their law. So it would need to be specific wordings so the healthcare organizations, the insurances, and the patients can understand themselves, hey, what's going to be covered and how can we go about making sure that there are no unexpected payments or fees associated with it.
Thank you. Good job.
Thank you.
Okay, I think that brings us to the end of all the presentations for the fall 2020 Capstone presentations. Thank you everyone for your presentations. It was excellent to see the good work that has been done in the last semester or two, depending on how much time you've taken. But congratulations everyone, and please upload your presentations and your reports in the OneDrive folder that has been created. Please communicate with your mentors for getting their signatures on the second page of the report template for approval, and please work with your mentors for advisors for the grading that you receive for this, which depends on both the presentation and the report. Dr. Jones, do you want to add anything else before we finish?
congratulations to all those who presented. Very nice work. And we are looking forward to your final revision of your paper. You're almost there, almost done. Thank you so much.
Okay, thank you, everyone. Bye-bye.
Thank you, Professor.
Bye. Thank you, everyone.
Thank you.
Bye. Thanks for all the hard work.
Thank you, Professor.